Assalamu alaikum. This is Dr. Jaidaa Mekky. I'm an associate professor of neurology at the neuropsychiatry department in Alexandria University. Today I'm going through the history taking for a neurological case with you. First of all, you should always remember that history taking is an art. You should be a very good listener and take all the relevant and important informations from the patient. Ask about the other necessary informations. And sometimes we omit some unnecessary informations to reach a proper diagnosis. We take the history from the patient himself or sometimes from a legal guardian or a relative in case this patient is comatose, demented, mentally subnormal, or something like that. So the personal data we are going to take is the patient's name to be able to communicate properly and politely with the patient for his own identification and for his filing system. The gender is also identified and age of the patient. Some neurological disorders occur in females more than males, like multiple sclerosis, for example. Some disorders occur late in age, like atherosclerosis or neurodegenerative disorders. Then we take the patient's occupation, his current occupation, and his past working history. And if the patient is ill or severely ill, we must know when did he stop to work, because this might be an indication of the severity of the current illness. We also take his address and previous residencies, whether this patient is from the same country or another country, or he is now living in a certain area and he is coming from a different region, because this might give us a clue about the original disorder that is related to something endemic in a certain area, and we are now suffering from the complication of this endemic problem. We document his marital status, married, divorced, or widowed, how many children does he have or she has, the date of admission to the hospital, and the handedness. Is the patient right-handed or left-handed? Usually right-handed patients have a left dominant hemisphere, and this gives us the information of the dominant hemisphere we are dealing with. The next item is the patient's complaint. We need the patient's complaint. Each complaint is identified and the duration of each complaint is documented. So I might have headache since 3 months, weakness 1 month ago, and so on. Don't put any new complaint in the present history, and don't miss any complaint in the complaint section. We have many neurological complaints that should be documented, and in case the patient does not mention them, we should ask him. So we have motor symptom complaints, like having weakness, cramps, or wasting, or having an involuntary movement that we will discuss briefly in the history. Sensory manifestations are very important. Sometimes we have an imaginary baseline where the patient is complaining of. Anything less than this baseline is called a negative symptom. Anything above the baseline is called a positive symptom. So the patient might tell us, I'm having hyposthesia. Hyposthesia means that the sensations are less than normal. Or anesthesia, where he does not feel anything at all. Or he will tell you, I have paresthesia, which is abnormal sensations. Or hyperalgesia. Hyperalgesia means there is exaggerated sense of pain. He perceives painful as more painful. Or allodynia. Allodynia is perceiving the non-painful as painful. In this case, the patient will start to perceive touch as a painful stimulus. The third important family of complaints are the cranial or bulbar manifestations. Whenever we have a problem like dysphagia or facial asymmetry or sensory manifestations in the face, we are directed that the brain stem is affected, which is the bulb of the brain. Thus, we call them bulbar manifestations. Also remember that the optic nerve and olfactory nerves are direct tracts to the brain. They have some connections with the brain stem, but they do not originate from the brain stem or do not relay in the brain stem. We should ask the patient about his sphincters. Does he have any problem with urination, like urine incontinence or urine retention or hesitancy or urgency? Does he have fecal incontinence or constipation, which is related to the rectum or rectal functions? And we should ask him also about his sexual complaints. Does he have impotence, failure of erection, or something like that? Headache is a very important manifestation, and we should always ask about headache, and we will discuss how to analyze headache briefly. Ataxia or imbalance is an important complaint that might note or might draw our attention to a problem with the cerebellum. Convulsions or seizures are a very important complaint that we will discuss also briefly now. And sometimes the patient has a problem with aphasia, memory, or skilled movement that usually come from the cerebral cortex. If he complains of something like that, we might be paying some attention to the high cortical functions or the cerebral cortex. So, in case our patient is complaining of headache, I should ask, when did this headache start? Does this headache come in attacks or is it continuous? How long is the duration of this attack? Where does it occur? Where is the pain? What is the character of pain? Is it a throbbing pain, like in case of migraine, for example? Or is it lancinating or dull aching pain? Where does it radiate? How severe is it? Is there any relieving factors for this headache or something that exaggerates this headache? Two very important questions are, does this headache have positional variation? So whenever the patient leans forward, like for example in al-sujud during praying, he tells you that the headache becomes intolerable. That means that this is a headache related to increased intracranial pressure. And there is something else called diurnal variation. If I have a diurnal variation of headache, where the headache is worse early in the morning, this happens with bad sleep or insufficient sleep. It happens with sinusitis, but it also happens with any increased intracranial pressure, because physiologically the intracranial pressure is very high early in the morning and it becomes less during the day. So if the patient has something increasing his intracranial pressure, like a space-occupying lesion, he will suffer from the headache early in the morning, which is worse than late at the day. If the patient has a problem or involuntary movement, I should ask him, when did it start, at which age? Does it come continuous or interrupted? Like for example, Parkinsonian patients have the tremors all the time. They're pill-rolling manifestations all the time. While patients with tics, they have them in attacks. Where is it geographically described? If, for example, the patient tells you, I have tremors in my face, my eyes, my tongue, and my hand. Or is it just confined to one area? What increases this involuntary movement? Almost all involuntary movements decrease during sleep except for myoclonus. Almost all involuntary movements are exaggerated by stress. Can you stop this involuntary movement or not? So tics could be stopped, while seizures could not be stopped. Sometimes the patient comes complaining of seizure as an involuntary movement. Okay, then what about seizure, which is a very serious complaint? We have to subdivide our patients. Are they epileptic or non-epileptic? In case the patient is not epileptic, I want to know, when was the first seizure that happened? Was it provoked or not? What does it mean to be a provoked seizure or to have a provoked seizure? Factors that might provoke a seizure are numerous, among them fever, head trauma, intoxication, drug administration. So in case this happened due to something like that, I should document that the first seizure was related to a certain stimulus or a certain provoking agent. If it is not, then it is an idiopathic seizure, and I will be inclined to think more that it might be epilepsy. How does it look like? Is it tonic or tonic-clonic or myoclonic or atonic? This is how we describe a seizure. How long is each seizure? Does the patient have a post-ictal period with certain characteristics? And how long is his post-ictal period? Because sometimes you as a physician might meet the patient at the post-ictal period, and in the patient's post-ictal period it is common to have something like hallucinations or thought paralysis, or the patient is sleepy. So you should know what happens with him after the seizure. In case he is known to be epileptic, okay, does he take his medications? Is he compliant? What are the medications? Did the patient need to enter the hospital or the ICU in the last few months or few years? You should document that very well to have a complete picture for the seizure, as well as any chronic medical illness the patient has, to be able to reach what is the cause of this seizure in case he is not epileptic. The next item is the history of the present illness. After taking the complaints, please remember to give me a coherent story. What is the onset of the complaint? How did it run? What is the course? Do I have any associated manifestations? Did he do any investigations for this illness? Or did he receive any treatment? What treatment? And what was the response to treatment? In case he received a treatment, did he go to a complete remission or to a cure, or was it a partial remission? And the negative data are worth mentioning at the end of the present illness, history of present illness. So whenever the patient tells you, I have a sudden onset means it's either embolic or traumatic. Acute onset, which means within days, it is usually due to infections or vascular insults or demyelinating or toxic accidents. Subacute onset, that means it's a matter of days to weeks. This comes with immune-mediated disorders or metabolic illnesses. If the patient is complaining of a gradual onset and progressive course of something, then I think about space-occupying lesions or neurodegenerative disorders. What about the course? Is it progressive, which means it is increasing? Is it regressive, which means it is decreasing? Or is it a stationary course? Or does this illness come in remissions and relapses? It increases and decreases, like in demyelinating disorders or immune-mediated disorders in general, this might happen. After finishing the present history, I should ask him about the past history. Do I have this same condition? Did it occur before or not? Do I have a similar condition or any other chronic medical condition like diabetes mellitus, hypertension, liver condition, allergy? Is he allergic to something or not? In case the patient is a chronically ill patient, is he on any regular medications or not? Is he compliant on his medications or not? Or is he a substance user? This should be mentioned in the past history. Anything in the past history should be after the end of our story. For example, if the patient's current illness started 3 months ago, then anything before these 3 months is usually in the past history of this patient. Another important item that we should pay attention to is the social history. What about the patient's lifestyle? How many hours does he work? What about the stresses in his life? What about his dietary habits or timing of eating? What about his sleep habits? When does he sleep, or does he sleep enough or not? This is very important to some specialties, like the dietary habits is very important for the dietitian or the nutritionist. A sleep habit is very important to someone who is practicing sleep medicine or asking the patient about 1/3 of his life during sleep. Last but not least is the family history of the patient, which is, do this patient come from a consanguineous marriage? Consanguineous marriage means that the parents, the father and mother, are relatives. So in case we have positive consanguinity, this raises the possibility of having something like a hereditary or a genetic disorder. Do we have a similar condition in this family? For example, if the patient has a cerebrovascular stroke and his father had a cerebrovascular stroke, so we have a positive family history of stroke. While sometimes we don't have the same illness in the family, but an illness related to my problem. So if the patient has cerebrovascular stroke at a young age, and we have a positive family history of familial hypercholesterolemia, this means that this might be the cause for his stroke in a young age. So any other illness in the family is also worth mentioning. If I have some, for example, his acquaintances or the ones living with him at home having, for example, manifestations of tuberculosis, this might give me a clue that the condition I'm dealing with is related to TB. When we finish the history, we usually know what is the lesion, what is the pathology. Famous pathologies we are dealing with in neurology are cerebrovascular insults or vascular pathologies, demyelinating pathologies, neurodegenerative disorders, toxic, nutritional, metabolic, hereditary. We should know what is the pathology we are dealing with, and we are going to diagnose the disorder based on the information of the history, while the examination tells us where is the lesion. And I will leave you here to my colleague to explain the neurological examination for you, and I hope it was beneficial for you. Thank you very much for your time, and see you in the other lectures.